Welcome to this episode of Guts and Glory. In this episode, we are going to address one very complex area. I would like to say that it is a confusion at the junction. And what junction we are talking about is gastroesophageal junction. And to discuss this, I have a very eminent personality, Dr. Inian Samarasam, who is the professor and head of surgery and leads the upper GI unit at the prestigious CMC Vellore. Now, Indian has done tremendous amount of work, and he is a leading authority in upper GI, esophageal, and gastric cancers. And I've been really impressed and learn a lot whenever we hear him speak in any of the meetings. And I thought, who better to address this controversy than Indian himself? So, Indian, welcome to this podcast.
Thank you for inviting me to this podcast. It's indeed an honor and privilege to be here, and I'm really, honored and humbled by your words. I agree with you that this area is something that I have been sort of interested and fascinated about, and I'm very, very happy to share my thoughts regarding this. Thank you very much.
So, Indian, straight off, one thing comes to my mind that how did you get involved in like esophageal gastric surgery, considering that most people look at HPB as the glamorous area in GI surgery? So, how come you got involved and interested in this? What's the story?
Well, I think I'll just go back a few years, starting from my surgical training. I actually did my surgical training, my MS general surgery in Calicut. And when I started my surgical career there, I was initially posted in a unit which was headed by Professor Warrior was his name. And he was the person who was doing esophageal surgery in the whole of North Kerala, if you want.
Okay.
And I was posted in his unit, and I spent quite a bit of time, in that particular unit. He actually did transthoracic as well as transhiatal surgery
Right.
in Mumbai. So anyway, that was my first sort of experience with upper GI surgery, and then subsequent to this, I joined CMC Vellore. General surgical units sort of got divided into different specialty-oriented units, and I sort of got an opportunity, if you want, to join the upper GI unit. And in fact, there was a vacancy there at that point in time. And I joined there. And subsequent to this, I thought maybe I should sort of learn a little bit more and went over on study leave to Australia. And I did an upper GI fellowship there. And that truly changed my perspective of this whole thing, where I was able to see sort of things. I mean, the volumes were much lesser than what we were doing in CMC at that point in time.
Right. Yeah.
That opened another dimension to this whole thing. And when I came back to Vellore again after my study leave, I sort of put those things into practice. And that was a huge satisfaction to see sort of, okay, we can do these things.
Yeah.
So that's my background to esophageal surgery. If you
I find that that's one institutions in the country which diligently divided these units into areas which people focus on. So upper GI, colorectal, HPB, and it's a fantastic concept in an institution and can be should be replicated. Yes. So I want to hear from you that what do you think has changed? How do you see the milestones in this uh, evolution of esophageal and upper GI surgery in the last 2 decades?
what I would say is, as far as the sort of milestones and landmark things that have happened in as far as surgery is concerned, certainly minimally invasive surgery has really sort of changed the outcomes in this. I think all the other things that go along with it, like basically the planning the multidisciplinary. I think that is another huge thing that has happened as far as esophageal surgery, like with any other surgery.
We trained with Dr. T.K. Chattopadhyay. You would know who was a brilliant esophageal surgeon. And we learned from him the transarterial esophagectomy because that was his forte. But I think I agree that the things have changed dramatically, in terms of understanding of the disease, the nodal clearance, realization that multidisciplinary is the way and not surgery. I think those things I quite agree that things have just, the landscape has changed, isn't it?
Absolutely, and of course the tumor biology, etc. I mean, where we look at personalized medicine, I think also has esophageal surgery in the recent years that has evolved.
Outcomes also have changed dramatically. You think in both in terms of immediate morbidity, mortality, and long-term survivors?
But definitely, the most significant mortality was pulmonary related complications. Patients used to spend long times in ICU, tracheostomies, etc., etc. But now with minimal invasive, I think it is definitely, I think, changed the picture. Where certainly in terms of long term, I mean, it's so very satisfying to see patients who we've operated 10 years, even 15 years down the line. I mean, certainly it's not for all comers, but we
Yes.
do long-term survivors as well. So I would say definitely we are looking at maybe not dramatic, but certainly our outcomes both in short term and definitely also in long term have improved and evolved over the years as far as esophageal surgery is concerned.
I said that I want to focus on the junction, the G junction, uh, because I find a lot of challenges to both in terms of diagnosis, treatment decisions, surgical plan, and so on and so forth. And I want to explore that with you. Let's start with that, the classification, the classic Sievert's classification of these three types. What was the genesis of this classification? What is the clinical value of this, and how does it impact, when we take decisions both in terms of in the clinic? We'll come
Sievert's classification, if you go back, it was in the late 80s that a series was published initially, and this was for lower third adenocarcinomas in particular, and this was the Sievert-Stein classification, if you want. But nobody took too much notice of this until about a decade, till the late 90s, probably 97, 98, when there was a publication in the British Journal of Surgery, when Sievert's classification was actually sort of put into for junctional tumors. And that's when the ISD and the Japanese classification also incorporated Sievert's classification as something that needs to be. So basically, we all know what Sievert's classification 1, 2, and 3. One is when you have tumors on the esophageal side, basically starting from 5 centimeters to about 1 centimeter from the G junction. Then the true junctional carcinomas, which are tumors which straddle the gastroesophageal junction. So basically, these are tumors which start about 1 centimeter above and go on to a couple of centimeters below the gastroesophageal junction. And of course, the third type, where the tumors are centered around on the stomach side, so basically from 2 to 5 centimeters. Why did they actually look at it? Because when they looked at their population of lower third carcinomas, they found that tumors which are on the esophageal side are a little bit different in terms of the occurrence, where the male preponderance, if you want, association with Barrett's esophagus were much more common on the tumors on the esophageal side, as opposed to tumors which were centered on the stomach side, which behaved more like the classical stomach tumors. And also they looked at the nodal spread, and they also, the tumors which were on the esophageal side, not only spread to the abdominal nodes, but also into the mediastinal nodes, and in fact, even to the upper mediastinal nodes. So basically, the nodal spread, the tumor biology, patient demographics, and also the outcomes. I mean, the esophageal surgery, the tumors which are on the esophageal side probably had worse outcomes than the tumors which were on the stomach side. So that was the basis of why this classification came. It's purely anatomical. There's no biological sort of when it was started, but it was then incorporated into the TNMs, the AJCC or the TNM classification as well. It has stood the test of time over the decades since it was started. It's a reasonable classification, although not perfect. It is reasonable, and we are able to make some sort of decision making on the tumors in this area based on this.
What my point in this is that if there are small tumors on one quadrant of the G junction, perhaps it's easier to ascertain which type it is. But if you have a large tumor, a circumferential growth, uh, do you think we can ascertain this by endoscopy or by imaging? And how reliable is it?
As far as the Sievert's classification is concerned, there are certain limitations. And one of it, as you rightly said, is actually defining the gastroesophageal junction. There is endoscopic, there is radiological, and then there is histological definitions. But then in a patient who has got a tumor where the anatomy is distorted, it's very difficult, number one, to actually determine where the G junction is or the gastroesophageal junction is. So that is one major limitation. And if you look at it, as you rightly said, if you have a large tumor which is straddling the junction, then obviously the anatomy is going to be distorted. And so if you actually look at the literature, there is a disconcordance of up to about 30 to 40% after good radiologic, endoscopic stage. These are definite limitations with the Sievert's classification.
So you have a G junction tumor, adenocarcinoma. What are the investigations you would recommend doing?
Proper endoscopy, I think, is really crucial for these patients. Many times they come with already an endoscopy report. I would say, as an operating surgeon, it is good if you actually are present when you do it, or you actually do your own endoscopy. Good endoscopy, which where you actually look exactly at what you're going to do for these patients, I think is crucial. Of course, when you do an endoscopy, then the biopsies. Now we are doing the biomarkers as well. So in addition to the routine histology, we look at PDL1, the HER2, and the MSI. So these are the three biomarkers that usually get done with newly diagnosed. So this is the current recommendation as well. A good contrast enhanced CT scan of the chest, abdomen, pelvis is still the current recommendation. Well, we know that a PET CT scan truly adds more value as far as metastatic disease is concerned. PET CT scan truly upstages the disease in about 20% of patients. So it does add value to this, particularly for metastatic, not for local disease at all. The third, the staging investigation would be a staging laparoscopy. If you look at when you would do a staging laparoscopy for these patients, for a type 1 tumor, perhaps it's not so crucial. But for a type 2 and a type 3 tumor, certainly a staging laparoscopy definitely is a must. And if you look at the timing of the staging laparoscopy, has to be done prior to the neoadjuvant therapy. You add cytology to it to look for peritoneal disease as macroscopic and microscopic peritoneal disease as well. As far as other staging investigations like endoscopic ultrasound, etc. are concerned, they are optional. It really depends on, endoscopic ultrasound may not be possible in most patients because they are circumferential tumors. Only if there is any doubt of, let's say, a node in some abnormal location which we want to do an FNA or have very early tumors. If you have a T1 tumor where you're looking at trying to do something endoscopic as a curative thing, certainly endoscopic ultrasound adds value. But certainly US is not something that we regularly do.
How often do you see multicentric disease? And second, do you make concerted effort to get into the stomach, to see the stomach and the extent of this, even if it entails dilating the tumor?
Synchronous tumors, is not so common as opposed to squamous cell carcinoma, which is basically a field change and you can get tumors in different locations. But of course, if you do narrowband imaging, etc., maybe you may pick up, but it's certainly not something that we see very often. And to the second part of the question, I think it's a little bit dangerous to sort of be over adventurous trying to dilate. So it's not something that we regularly do to dilate and go and look at the rest of the stomach. But certainly, if we have not looked at it after the after the neoadjuvant treatment, certainly we would add an endoscopy there to look at the rest of the stomach as well.
What would you say is a dramatic or paradigm change in the management strategy of these tumors?
As far as the paradigm change, I would certainly say neoadjuvant therapy for now. I think surgery is an important component, but obviously the neoadjuvant therapy that goes along with it has evolved quite a bit, and particularly currently in this era, with immunotherapy, in addition to radiotherapy, chemotherapy, I think immunotherapy has actually. I think we're going to see huge change with the advent of immunotherapy. And also the other things that go along with it, like the multidisciplinary approach with the getting the patient ready for surgery, like the prehabilitation, the nutrition, all these things I think have evolved, and I think they have made a huge difference to the outcomes both short term and long term.
I was wondering that there is a patient with dysphagia. You want to do a neoadjuvant therapy. How do you provide nutrition to them? I mean, do you put a stent or you put a tube? You do a feeding port? How in your patients do you get the nutrition in this critical phase of neoadjuvant treatment?
So in our practice, if the patient has significant dysphagia, then we would try to pass a tube across the tumor, like a nasogastric tube.
Any role of stent during the neoadjuvant phase?
As a bridge to nutrition during that phase, we haven't used it for one, I guess, for cost purposes. It adds a different dimension to the thing.
What about feeding jejunostomy when you're doing a staging laparoscopy?
I think some centers practice it. It is not our practice to do that at that point in time. It's not common practice, but I totally agree with you. That is one of the options available.
So most patients now would get neoadjuvant therapy. Any thoughts on radiation as a additional component or only chemotherapy?
For squamous cell carcinomas, cross regime seems to be the popular one, and it is
Standard recommendation.
For adenocarcinomas, it is usually neoadjuvant chemotherapy alone is what we follow, and we follow the FLOT regimen. But having said that, there is variation in different, geographies world, what is being followed. For example, the Japanese would never give radiation, whereas in the West you would see radiation being given. So the Japanese have done a trial called the NEXT trial, and they have compared chemotherapy to chemoradiotherapy for squamous cell carcinomas. And in fact, they have found that triplet chemotherapy is equally, if not better than cross, even for squamous cell carcinoma. So essentially, it may be that we are looking at chemotherapy for squamous cell as well. As far as adenocarcinomas, because we are now talking about junctional tumors, basically what is the regime that is used across the world. And the recent trial, which actually they compared FLOT and cross for adenocarcinomas, and this trial is called the ESOPIC trial, and they have clearly demonstrated that FLOT is better than cross for adenocarcinomas. So there is no doubt that FLOT for adenocarcinomas. As far as squamous cell carcinomas, it used to be cross, and it is still cross. Maybe we may see some change with chemotherapy, even for squamous cell carcinomas. Now, I'm not even talking about immunotherapy here, but that is something that's also evolving. And we've got trials like the Checkmate and the Keynote trial, which have looked at adding immunotherapy both to the adjuvant phase and also to the neoadjuvant phase. So we are looking at both. Of course, cost is now a factor, but I'm sure in the coming years we are going to see some change there as well.
Thanks for clarifying that and putting it very clearly that there should be no confusion. When do you operate? How many cycles and what is the interval between chemo and surgery?
So for FLOT, we give 4 cycles of FLOT, 2 week intervals. So it roughly comes to about 2 months of chemotherapy, a period of about 4 weeks for the patient to recover, and then surgery. If the patient had chemoradiotherapy, basically it is a cross regimen. It's 21.4 grays of radiation along with 5 weeks of chemotherapy. It's a concurrent chemoradiotherapy. Here is where a little bit of debate of when you actually go in. Usually it is between 4 to 6 weeks. And that seems to be a period when
Yeah.
things are ideal to go in. If you wait a little bit longer, then fibrosis starts to set in. As you know, the SANO trial, which actually looked at postponing surgery, waiting for a little bit longer, till the patient gets the tumor, and then you go back and operate. So, firstly, they wanted to make sure that postponing surgery doesn't increase the morbidity.
Yes.
So, and they actually clearly showed that this is not the high dose radiation that you give for radical chemotherapy. That is about 50 gray. Cross regimen, which you give as a neoadjuvant chemoradiotherapy, we may be able to wait a little bit longer, seems to look at it. And if you ask our experience, we've sometimes had patients who have missed coming back, or
Yes.
they've had their chemoradiotherapy elsewhere and they come back 6 months later. Initially, we were very, very scared to operate on these patients. And I can vividly remember, saying no to some patients because they came 6 months later and we were very
Yeah.
scared to operate. But when we started operating on them for this low dose, like I'm talking about the traditional dose, it wasn't so difficult, and in fact, it was almost equal. So I would say that the 4 to 6 weeks interval is not sacrosanct.
Yes.
It would be good to go in, but we are going to, in the next era, see patients or the borderline patient where you think, look, this patient is not so suitable for, not the young patient, but maybe a borderline patient. And if there is a complete response,
Good complete response.
maybe those patients, we may be able to offer a little bit delayed operation as well.
When you look at other GI malignancies, say for example rectal, and in that also data is coming that you delay the surgery. Earlier, same thing, 6 weeks, and now even people say up to 11 weeks. And the longer you wait, it seems the response rate is still better in some of these without jeopardizing the outcome of surgery. So it's taking leave from there. The challenge which now I feel, Indian, having done all this, is to choose what surgery you are going to offer to that patient, the extent of surgery, and especially that the junctional one, the type 2 one. How do you choose what procedure you want to do? You want to do a subtotal esophagectomy, you want to do a total gastrectomy. So, how do you go about planning that part of the surgery?
Sure. I think this is probably the most interesting and the sort of, if you want, controversial
Yes,
area here,
and
uh,
challenging,
and challenging as
especially
well.
decision making. This is what I face most of the time.
I would like to first start by saying this decision has to be made before you start giving any form of chemotherapy or radiotherapy, etc. So it is an upfront decision made in the multidisciplinary meeting. The real controversial area is the type 2 tumors. I would just like to sort of add here that when we say type 1, type 2, type 3 based on C words, we're talking about the epicenter of the tumor. Now, obviously, the CWAS does not talk about the proximal and the distal extent of the tumor, which are the two crucial things that we need to know when we decide on what operation to do. This is again one of the fallacies of the CWAS classification. The CWAS never talks. So you can have a tumor with an epicenter located right at the G junction.
Yes.
I'm just quickly saying it can extend 5 centimeters up,
Uh,
it extends 5 centimeters down, or it may extend just 1 centimeter up and 1 centimeter down. Both have epicenter just at the G junction or the gastroesophageal junction, and both are type 2 tumors according to Sievert's classification. But in no stretch of imagination can you do the same operation for both these patients. I think it is crucial to know the proximal and the distal extent. So if you know the proximal and the distal extent, and this is where I think a proper endoscopy, a proper look at the CT scan. Well, these are the things that we
Yes.
have to actually
Yes.
sort of do this.
Yes.
Not to the millimeter, but certainly we can sort of say, okay, this is roughly 1 centimeter or 2 centimeters above the G junction. So that is the first thing. Now, there are three questions you need to ask yourself. Firstly, how much of bowel proximally and distally do I need to access? Well, like the margins. So basically, what are going to be the margins? The second question is, how much of lymph nodes do I have to remove to do an oncologically appropriate resection? And the third question is, what type of conduit do I use? Like, can I use the stomach to be
Yeah.
more specific? So these are the three crucial questions that you need to ask yourself. It has become a little bit more clearer because now the current Japanese classification um, clearly defines how much of lymphadenectomy you need to do based on the extent of the proximal extent.
Yes.
So if you have a tumor uh, less than 2 centimeters from the gastroesophageal junction, then you really don't have to do any major lymphadenectomy in the chest at all. You just clear the nodes around the hiatus and till where you're resecting. Suppose you have a tumor more than 4 centimeters from the gastroesophageal junction, then you clearly have to do a lymphadenectomy, a mediastinal lymphadenectomy, sometimes even definitely an infracarinal. So basically going up to the carinal lymph.
Yeah.
And even if you have tumors which are bad, etc., you need to even clear the 106, which is the recurrent laryngeal nodes as well, because even for lower third carcinomas, there is a 5 to 10% incidence of tumor, sort of nodes in the along the recurrent laryngeal nerves. So it's very, very clear now. So less than 2 centimeters, you really don't have to. More than 4 centimeters, you have to clear the mediastinal nodes, at least the subcarinal, up to the subcarinal nodes clearly. And for between 2 to 4 centimeters, you need to clear the lower esophageal lymph nodes, which is basically station 110, 111, and 112. So essentially, the nodes along the lower part of the esophagus, not even going up to the subcarinal lymph. Now, again, based on the same formula, 2 to 4, and 4, you then decide on what type of operation would give you a negative margin. So if you have a tumor which is less than 2 centimeters, certainly you will be able to get a decent margin, a negative, microscopic negative margin. You need to give at least 2 centimeter margin.
That's the thing. How much? 2.
Yeah, so
2 centimeters.
2 centimeters. You will certainly be able to do a transabdominal approach, like a total gastrectomy, or very rarely a proximal gastrectomy, and try to get a margin from the transabdominal side without going into the chest. So if you have a tumor, more than 4 centimeters, there's no way you can get a margin. So you are looking at a transthoracic approach or some form of an esophagectomy to get a margin. And again, this 2 to 4 centimeters, it depends on, not only the tumor, but also on the patient, are they going to be fit enough to have a major resection, et cetera, in order to decide whether you're going to sort of go into the chest or whether you can sort of manage in the abdomen. So between 2 to 4 centimeters, basically you can do a total gastrectomy, or if you're doing a transthoracic approach, an Ivolus esophagectomy, or another approach which can be used is the left thoracoabdominal, which is an open technique. Basically, you open the abdomen and go into the left side of the chest, and you can get more margin into the esophagus. As far as the distal extent is concerned, basically, if you have a tumor up to about 3 centimeters from the gastroesophageal junction, the lymphadenectomy that you do can be very limited. It can be nodes along the lesser curvature and maybe station 7. When I say lesser curvature, you don't even have to go to station 5. And then 3 to 5 centimeters, basically you leave station 5 along the lesser curvature. Basically, something like an Ivor Lewis operation is possible if you have a tumor up to 5 centimeters along the lesser curvature. And if it is more than 5 centimeters, you need to do a standard D2 lymphadenectomy. The amount of stomach to be removed also, if you take the same 3 centimeter, 3 to 5, and 5 centimeter, if it is 3 centimeters, you may be able to get away with a with a proximal gastrectomy, providing you don't have a very bulky tumor. If it is 3 to 5 centimeters, you can definitely do an Ivor Lewis operation. You can leave all the nodes behind that you leave for an Ivor Lewis operation, and then also you will be able to get a margin. Whereas if the tumor is more than 5 centimeters into the stomach, then, or if it is involving the fundus, certainly you cannot use the stomach as a conduit. You have to remove the stomach.
Do you always do frozen of the
If,
margins
if there is a doubt, like for example, if it is a 2 to 4 centimeter tumor and then we are trying to do a total gastrectomy for this patient, certainly tell the pathologist that we might send a frozen. We don't do it routinely. So to answer the question, not routinely, selectively we do. And also, I think selectively an intraoperative endoscopy certainly helps. Negative margin is crucial. And I think we should do our best to get a negative margin for these patients.
Sometimes what happens, this personal experience that you are above the tumor, you get and you think it's adequate margin, and you transect there. You see that the mucosa, there's no disease or no tumor, but there is a periesophageal or submucosal spread, which you may not know, and then the final thing comes as there is a tumor at the margin. Has it happened? Does it happen often?
It certainly does happen. I think that is purely because, like what you said, it all looks okay, but then we have submucosal spread. So if we do get that kind of, if we do a frozen and you get a positive margin, you go back and revise it.
Yes, yes.
As if it is a post-operative thing, then obviously this needs to be taken on a case-by-case basis. I think if you have a large tumor burden, like if it is more than 5 nodes positive, then obviously the patient is more likely to get recurrence.
Yeah.
I mean, it's tumor, so you wouldn't go back in. It's very, very unusual that you have to go back in where you have very little nodes and then you have to go and revise it. Personally, we have not done it. So I think if there is a margin positivity, then our fallback has been to give post-operative radiation for these patients, in addition to the adjuvant chemotherapy.
Right. Makes sense. So, Inian, talk a bit about reconstruction. What are your options and what do you prefer using or doing the reconstruction with?
The best choice would be using the stomach, if you can use it. Basically, if you have a junctional tumor where you need to go into the esophagus, and if you're able to preserve the stomach, an Ivor Lewis operation is our preferred choice in patients whom you need a proximal margin lymphadenectomy proximally, as well as you can preserve the stomach as a conduit. Good intrathoracic anastomosis, it's a good thing. If you do a total gastrectomy, obviously jejunum is our preferred conduit, and there are instances where you may have to remove the stomach and then also go into the chest. For example, if you have a tumor which goes, say, about 4 centimeters,
4 centimeters.
If you can't get a margin from below, an intrathoracic anastomosis using jejunum, but also I should mention good practice to prepare the colon. You can use it if necessary. Those would be the choices. So if stomach is possible, definitely stomach. If not jejunum, third option will be colon, which is prepared. And one other thing maybe I haven't really mentioned is the role of proximal gastrectomy. If you have a tumor, a junctional tumor, which is not more than 3 centimeters into the stomach, and it is not very bulky, there are not many nodes. So reflux is a major problem. Yeah. To circumvent that, you can use the sort of interposition, etc. But our experience with that is not very much. So we don't have much in our unit.
Do you ever make a pouch of jejunum if you're doing a total gastrectomy?
We our standard practice is to do a 1Y anastomosis without a pouch. There is plus and minus for doing a pouch. I think there is not much evidence in the literature in the long term to say that the pouch helps with the accommodating as for the stomach, but the jejunum sort of dilates over a period of. So in a year's time, I don't think it's any major difference. Maybe in the short term, but I don't think it adds too much to the quality of life, if you want. post gastrectomy.
Let's address the main thing now. Minimal invasive surgery in this. All patients, do you offer minimal invasive surgery, or there is a group of patients which you say, I will do open only?
I think as far as esophageal surgery, I think we have seen a significant difference in patients who have been operated minimally invasive. So if you look at our sort of evolution in our unit, we were doing open surgeries up until I would say 2010, 11, and then we slowly started doing minimally invasive surgery. That coincided with sort of overseas experience, etc., etc. So it will, we started for we started for squamous cell carcinomas, lower third, away from the carina first, uh, till we got a little bit more confident about uh, you know, the anatomy, etc. And then we started using we always used the DLT, and then we said, okay, fine, we'll just do with a single lumen tube, etc. So we slowly evolved, till we got more comfortable with our thing. But right now, we do minimally invasive for all our patients as far as esophageal surgery. Both McEvans and Ivor Lewis, we do minimally invasive. And I feel the huge difference is the chest, morbidity and
Pulmonary
complications,
complications.
which almost all our patients get extubated on table, and many of our patients come back to our ward rather than even going to ICU.
Vision is also much better, isn't it? Access is much better. You're not struggling as an open. I think this area is, there is no doubt that minimal invasive surgery is
I
made
cannot,
a
yeah,
great
I cannot
impact.
say not say the same for stomach cancers, because I think
Yes.
as far as stomach cancers, one, we see advanced gastric cancers, and number two is that particularly when you're looking at margins, proximal, so those kind of things, we don't really want to compromise oncological safety, and I really don't think it makes a huge as much as a difference avoiding a thoracotomy to avoiding a laparotomy. I think.
Absolutely. Let's bring in the robotic here, Indian. Now, I understand you're doing robotic surgery, and a lot of people are embarking on this journey of robotic, specifically for esophageal cancers. How do you see robotic versus laparoscopic minimal invasive surgery? Is it a game changer? What are the benefits you see, if any, of robotic over, say, a standard laparoscopic surgery?
Jump from open to laparoscopic was huge. The benefit, I would say, from laparoscopy to robotic is certainly nowhere near. I think as far as patient recovery, uh, except the morbidity, etc., the oncological as well, I would say, not very huge. Two things perhaps. One is the nodal dissection supracarina. I think that is one area where I think it definitely makes a difference.
Yeah.
Clearing the nodes, current laryngeal nerves is
Yes.
more, I feel it's a huge difference. So I think that is one area where I think robotic surgery, in my view, definitely is better. And the second area is obviously, in terms of, intracorporeal suturing and anastomosis, etc. The ergonomics, the sort of,
Yes.
also you can do it. You can be a very good surgeon and you can do the same thing, but I think
Yes. Yes.
that adds to the thing. But
Yeah.
apart from that, I don't think it's a huge game changer.
How do you use the Firefly mode? Is that a additional advantage?
Yeah, it certainly adds. Now that we do have laparoscopic consoles as well with the same thing,
Yeah.
but certainly with the robotic, which definitely it is always there. So definitely, so as far as the thoracic duct is concerned, when we started doing this, we actually did it for every patient to see the anatomy of the thoracic duct, etc. So if you ask me, is it crucial, and if it has it sort of made a huge difference? I wouldn't say no, but certainly it is an added benefit. We certainly look at the vascularity, etc. Did we have to change our
Yes.
intraoperatively? I would say it isn't that, it's not that much of a game changer there.
Yes.
But it's a huge thing that it is there, and if you really need it, it is there. So
Yeah.
I
It's
think
just a kind of, it provides you that comfort that you can look at the vascularity. And
then
generally,
and then when you sort of see this bright green glowing, you
yeah,
feel you've done a
yeah,
good job as well. So
yeah.
it adds a little bit of personal satisfaction.
How do you choose who to offer robotic?
I think basically two things, sir. One is affordability, and second thing is availability as well, because we have one robot for the whole
Yeah.
hospital. So we get limited share of our sort of operating time. For our esophagectomies, we offer robotic to the patient if they are affordable.
The final thing which I want to, pick your brain on is that what are we looking at in the future? So we've seen the evolution, we've seen where we have come. What do you see, say, in the next 5 to 10 years in terms of which is going to have an impact on treatment and some surgical innovations, if any?
Yeah, I think what we can see in the horizon for esophageal surgery, one is of course the evolution that has happened. I'm sure we are looking at more in terms of surgical sort of outcomes, etc., improvement. And if you ask me how that is going to happen, I mean, uh, as we were talking, I think. Obviously robotic surgery adds a little bit more, but I'm sure we will see particularly with the advent of better neoadjuvant and adjuvant therapy. So I think that is another area where we are going to see a huge change in the practice, if you want, of patients. And I can clearly see immunotherapy sort of
Mm.
stepping big way as far as esophageal surgery is concerned. And what I feel very excited about is in terms of the outcomes of patients. I mean, it doesn't necessarily have to be surgery related, but I'm very optimistic that we are going to see better outcomes for patients with esophageal and gastric cancer with everything put together. I mean, I'm talking about not only surgery, but the whole gamut of things. And lastly, I also see that, with all this coming there, I know you started by saying not many young people are interested in esophageal surgery.
Yeah.
And I'm sure we're going to see more people, more young people, more young surgeons
Yeah.
being interested because the outcomes are better, not only, short term, but also long term outcomes. And, this is, I can see a truly evolving field, which is going to get more younger people sort of interested in. And that is one thing that I would really like to see in my lifetime, a
Yes.
change perspective of how a young surgeon looks at esophageal surgery. And I'm sure it is bound to happen.
And I feel, this era of specialization in an area is going to have a definite impact in terms of the outcome uh, in this. Like, if you're focusing only on this esophageal surgery as you're doing or your unit is doing, it's bound to have an impact on the results. And now more and more people are going into that super specialization, if I may use that term, and that would have an impact. Thank you so much, Inian, for your time. And I think, it's a great conversation that we have had, and a lot of cobwebs have been cleared in this. Clarity has come talking to you. So thank you so much for joining in. And I'm sure the viewers and listeners would really enjoy listening to this podcast.
So thank you so very much for inviting. And